So I'm joined now by Dr. Hartzell Schaff. Hartzell is on the program committee and also obviously is a tremendous surgeon from the Mayo Clinic. Hartzell, you just gave a great talk about the repair revolution. So what was sort of your message with that?
Well, two things. I think there's, first of all, the underpinnings of the repair revolution have to do with the better understanding of the natural history of mitral valve disease, the availability of the imaging, primarily Doppler echocardiography, and then the simplification of repair techniques, which we talked about a little bit in the presentation. All of those have resulted in a decreasing risk of operation, and that has allowed surgeons and cardiologists to move ahead earlier in treating patients with mitral regurgitation.
You also, I mean, you pointed out, and obviously it came out of the STS data bank and Steve Bollig's paper, and about that really there's a threshold if you're going to do mitral valve repair, not only to have a good repair, but to have a great outcome for the patient.
Right. I think there's more and more information coming out that even though we appreciate, especially at meetings like this one, the advantages of mitral valve repair, it's not as widely disseminated in practice as we would like to think. And the fact of the matter is only about 40% of patients that have mitral valve operations have a mitral valve repair. And we don't know how many really are ideal candidates for repair, but it certainly is higher than that. And it looks like from the numbers that are available that the repair rate is optimized when the surgeon is doing sort of 30 to 50 mitral valve repairs a year or more, and an institution is doing 50 to 100 or more.
Hartzell, do you think, you know, the guidelines are obviously being revised right now, but it seems to me that a lot of times the practicing cardiologist has waited for the patient to develop symptoms or the LV to get bad, or them to have atrial fib. Do you think we have enough data now to say that we should really start evaluating those patients with organic degenerative MR and looking at earlier repair than what we've historically done?
Well, we've practiced that way for many years, and it's not, and I think it's an important distinction, it's not early repair in the sense that you're repairing it before it's severe. You're repairing or recommending operation when the mitral regurgitation is severe, but before there is a lot of end organ damage. Right. Now, and that, I think our experience has been replicated in several other papers. In this, there's a paper from Korea that showed exactly the same thing that we found in terms of the better outcome of patients who are operated on earlier for mitral valve regurgitation.
And then, you know, you certainly you did a great job with outlining all the features. If you had to look 10 years down the line, okay, where do you think we'll be with mitral valve repair? In other words, both technique, tricuspid is obviously and critically important in mitral valve disease. Well,
the thing I didn't talk about that there's going to be quite a bit on in this session is the different platforms for doing it. You know, there are surgeons now that are very good at robotic mitral valves, so the minimally invasive surgery, and whether that's applicable to everyone or whether it's going to be used at every center, I don't know, frankly. So I think that's something that will unfold in the next 5 years. The other group of patients, I think, if you look at Maurice's papers that look at the survival of patients with severe mitral regurgitation, the patients with severe regurgitation don't do very well. The ones without very much regurgitation do pretty well. Then there's this intermediate group. And the intermediate group, once you get out a year or two after their initial echo, they do about like the patients that had severe regurgitation. Now the issue is, did they turn into severe regurgitation, or is our threshold really, should it be lowered in terms of the volume of regurgitation?
This gets into the whole question of watchful waiting and how you do it, and you know, in the economics, you know, are we justified doing, you know, 6 monthly echoes on these people? It's very complex.
Right, it is, and it's not just for following the patients before surgery, but also afterwards. How often do you get the studies?
The final thing I'd ask you is that if you, you know, you've had a fabulous career in cardiac surgery. If you looked out down the line, okay, obviously the TAVI or TAVR and the eclipse and mitral clip and all that stuff is changing the whole spectrum. Where do you think cardiac surgery is going to be in 5 to 10 years? What's the cardiac surgeon going to be? It's an interesting question.
Well, Randy, it is. It's a big question,
I know.
and I'm not sure I have a big answer. But I still think that the surgeon there will be lots to do for the surgeon. And just as in coronary disease, as angioplasty supplanted surgery for the simpler cases, the straightforward aortic stenosis in a high-risk patient may be better treated with percutaneous, but there are always going to be patients that need surgical input. So it changes the kind of patients that we see, but I am sure that there'll be a role for young surgeons in the future.
Don't you, and it's also a mindset change with us in cardiology. In other words, the cardiologist has historically not really interacted in the surgeon's world. So this concept of a team, the surgeon, the interventionalist, the cardiologist, I mean, maybe at Mayo it's different, but in the rest of the world it's not. So the concept of a team really becomes important.
Well, I think the concept of a team is important, but if you step back, Randy, and think about this, that for every surgical procedure, there is a team. There's a cardiologist that refers the patient and a surgeon that does it. What we're talking about now is the team's a little bigger because there's another option for the patient, and that's the interventionalist. So surgeons are really not uncomfortable with the team concept. That's the way we've played the game for years.
Well, and I know that's true, but I mean the concept of, I was really going toward the direction of the valve clinic, the tumor board, that whole, so that you start seeing, you know, historically you'd have a cardiologist see a patient, then send it to you and say, Hartzell, what do you think? I think, you know, where getting that closer discussion on the difficult cases may be beneficial.
Right. Yep. Well, I think surgeons are comfortable with that concept.
I know you are. Thanks very much.
Right, thank you.
Appreciate it. Good.